active listening, non-verbal communication, and empathy that gives you a connect with the patient, and that will ultimately result in a therapeutic alliance, and that is crucial to compliance and examination and professional satisfaction. I think all of us know that when patient comes to us and say us that doctor, it is because of you only I am here. I think that satisfaction will never come on by technology. So these are the few things. And what will happen if we will not, what this technology did, that resulted in erosion of bedside teaching. I am very sure after my presenting the facts, you will accept that this is the real fact. Reduce patient interaction, blind faith in technology. I think we are going towards an adult autism where there is a cognitive complacency after using up so many AI softwares, leading to errors, especially in these AI systems, because all of us know that every patient is different. You need to start thinking in a different way, and you need to plan a different plan of management. Maybe 80% is common, but 10% you need to vary as per the patient context. There is a loss of clinical intuition. Many of the time the report comes normal, and still we think there is something wrong. And I think that is one point. As a doctor, we always feel there is something wrong, I am not satisfied with the reports, and you again repeat the report. So algorithm again take us with this particular thing, something is not right that you always think. And there is definitely a dissatisfaction among the relationship between the doctor and the patient. So I am not against technology, so this is absolutely no from my side. It is about finding the right balance, that is important. The bedside teaching used to be the theatre of learning. Now often it is replaced by the simulation lab and screen-based analysis. So are we really losing the human touch or the human heart of the medicine? So now there are a few facts I wanted to say about, just to confirm what I said till now, that whatever the studies available in the literature, almost the classical bedside teaching once accounted for almost 75%. This is in 1964, there is a paper published where it was written that the 75% teaching is a bedside teaching. And right just now the previous speaker said about the recent article is saying 10%. The literature available is still 15 to 20%, the bedside teaching is gone down. So this is the recent paper published where this is almost less than 10%. I am also going to talk about one of the studies where the time of giving the bedside teaching is only less than 1% in one of a particular hospital. Why this is happening? Because there is a digital learning platform, simulation labs and time constraints push the teaching away from the real patient towards structured screen-based formats, and the impact is that student gaining the access to data but lose the exposure to patient narrative and contextual cues essential to diagnostic tool. So what is the impact of this reduced bedside teaching? There is an erosion of the core clinical skill. There is a decline in competency. I think this is what we see in day-to-day practice, that our residents start with the investigation, that what is the investigation report is available. The systematic review published in 2017, 20, 22, there are many reviews after that. The systematic review reveals lower proficiency in cardiac auscultation. Now they are not bothered about cardiac auscultation. They immediately send the patient to the echocardiography. Similarly, neurological localization, the first investigation comes to our mind, we go ahead with an MRI. And many of the time, an abdominal examination for ultrasound. So these are the things probably the students are losing in development, that is proven by the various research. And so long-term education impact is we are losing the sensory diagnostic skill, weakens the clinical intuition, and mentorship continuity between the generation. So once stethoscope, I think the moment I joined the MBBS, the first thing I purchased is they took out the stethoscope. So stethoscope now became an ornamental instrument. Nobody, even many of the time on the wards, resident is not having the stethoscope. You need to ask someone where is the stethoscope. And even many of the time the veil is not there. They don't understand where is the veil is there or what is the role of those particular auscultation parameters that were teached by us. And now with time, with the advent of technology, there is an eye patient that generated. And this eye patient, the study published by Burgess in 2011, that physicians increasingly treat data representation of patient rather than the patient themselves. From 2011, we are having a concern of this thing. There is a decline in the empathy score. We are not empathy, we are just treating the patient. Our residents are just sitting there, just finishing the work and just passing on the time. There are studies from India is also there. Vishwas, Etel and Ozer from India, they reported the same finding. The consequences on patient care is a reduced physical interaction, weaken the communication, trust and satisfaction. So technologically measures better vitals than emotions. So that needs to be very important message that I wanted to give. So technology cannot measure the emotions. At the same time, as a teacher, I think as a teacher we also are a part of this particular technology invention. At this point of time, the AMA said that we are spending as a teacher 40% of the time on searching for the data or seeing the data or preparing the data. So we are on the screen for almost more than 40%. So, and there is an HR burden, so electronic health records is always there. We also need to search, and many of are really not trained or tuned in terms of electronic or learning this technology. So this is the problem that what we are facing. And this is resulting in the quality impact. We are having a cognitive load of multitasking. All of us are having a multitask available. And you can understand when teachers are distracted, prediction fail. So this is the similar thing that is happening right now. Over-dependence on diagnostic etiology. So there is an ease of access, decline of inquiry. We are sending the patient here and there for CT, MRI and point of care diagnostic. And many of the time was because that is also a physician, that is also a technician, that he needs to decide what type of study he wanted to do, what parameters he used to put in the computer. But as a clinician, we are not giving a diagnosis, we are not giving them a clue. We are just writing down a neurological disease, epilepsy disorder, and sending them to the MRI. We are not writing that what we really wanted to see. And that is the reason many of the time the report comes normal, or there is something abnormal come and then we will be in a haywire, why this is there. So this is a regular thing. And this is also reported in, I am not saying with my own experience, I am talking about the study publications of journals like NEJM and JAMA that describe the same thing in their literature. Overuse of imaging can lead to misdiagnosis or incidental finding that what we are using, and obviously the expenses that we are increasing on the patient. This technology, again, we are sitting at a GWALIOR or we are sitting at a Delhi or sitting in the Western countries, probably the technology at par. In many smaller cities, the technology is not that much. We are not training our student in that way, and that bedside teaching is must in that scenario, because there you don't know that where the student is going to go. The student may go to the periphery and he will not find all these answers, and there will be a problem. He will just refer to the higher center. Working at a tertiary care institute, I can say that many of the patients unnecessarily referred to a higher center because they don't want to make a clinical diagnosis, and it is very easy to make a clinical bedside diagnosis. So this digital divide becomes a clinical divide. That's what we are seeing in day-to-day practice. This is the final thing I want to say. Technology definitely reduced the burden of bedside teaching. The bedside teaching it came down, and one of the studies where this is an interventional studies they did, they planned out a 1 hour bedside teaching rounds, and they trained it, and they seen that when the pre-intervention, the bedside round is only less than 1% of the time they are using for the bedside round. But after this intervention, after this 2-month intervention, the bedside round, the post-intervention is almost 41%. So this is a very different, and that resulted because people say it took lot of time, unnecessary time, now the investigations are available. If you see the time per new patient, that actually came down. Because you are seeing the patient every day and you know that what is the diagnosis and what you are thinking, so next day the time duration is comparatively less. So the time duration is gone down, and total rounding duration is also not that much. So even though we are saying that technology will help us in saving some time because we are a multitasker at this moment of time, even that is not that really affected that much if you take a regular clinical bedside round. So this is very important. And so what I want to say and why I want to end and put my friend Dr. Tade, that my thought is really a shared medicine that is needed at this point of time. At this point of time, technology should be a powerful ally, but is working as a silent thief of connection. It is taking our things with them. Innovation must serve the empathy. 8% is eclipsing the empathy. Need to overcome the barriers of bedside teaching. A good clinician is not built up in server room. That is a very important message that I wanted to give, and I am very sure that all of you agree that technology in last 10 to 15 years is definitely reduced the bedside teaching, and the impact of this teaching is all of us are seeing in our day-to-day practice. So thank you, ma'am.